Hello, this is Mark Warshawsky from the American Enterprise Institute, and I'm very pleased to welcome you to an event on the 2025 Medicare Trustees Report, a Medicare at a Crossroads. This is an event that we have been here at AEI been sponsoring for many, many years. In fact, one of the panelists, Joe Antos, my colleague, has organized it with Paul Spitalnic, actually at CMS for I think going on 20 years, and so we're very pleased to be able to continue it. I've taken the role of moderator, and Joe, who is now retired from AEI, has graciously agreed to now become a panelist. So the order of the day is that I will turn it over to Paul Spitalnic, the actuary at CMS, who has shepherded the trustees report again this year, and will present for about 35 minutes. And then we'll turn it over to the two panelists, Joe Antos, for about 15 minutes, and then Paul Ginsburg from USC and Brookings Institution will also speak for another 15 minutes to make their points, questions, and comments and observations about the trustees report. Then we'll open up for questions. I will start with a couple of questions for the panelists and for Paul Spitalnic, and then we'll invite the panelists to also ask questions, and then we'll invite your questions from the audience. Please send an email to jordan.law@aei.org with your questions, and we hope to get through them when we get to that point in the program. So let me now turn it over to Paul. He has a slide deck presentation.
Good morning. Thank you, Mark, and good morning, everybody. It's my pleasure to talk through the key findings of the 2025 Medicare Trustees Report. The findings were released on Wednesday, and we'll jump right into what the order of the day is. So we're going to talk a little bit about where we are in the program and how we got here. Key results, get into some details and some additional material that we always try to add in something that is a little unique or a little interesting, and hopefully we'll hit those marks. So this is how the Medicare program is organized. There are two distinct trust funds: the Hospital Insurance Trust Fund, or HI, which includes Part A, which provides inpatient care, skilled nursing, home health care, hospice care, basically acute care setting coverage. There are about 67 million enrolled in Part A in 2024. And the funding for the HI program is very different than the supplementary medical insurance program. This is the one that is funded through payroll taxes predominantly, 1.45% payable by both employees and employers. There's also additional earnings for high income individuals are subject to an additional tax, and certain Social Security benefits that exceed a certain level are taxed, and a portion of that tax is deposited into the HI Trust Fund. This is the trust fund that typically gets the most attention around the release of the Medicare report. This is the one that has a depletion date, similar to the Social Security trust funds. And we'll talk a little bit about those financial results in a moment. You can see at the bottom, there's over $400 billion in benefits spent from the HI Trust Fund in 2024. Turning over to the supplementary medical insurance, this has two distinct accounts. There's no ability to transfer funds across these accounts, so these effectively operate as independent trust funds as well. The Part B, as in boy, trust fund account, it provides physician services, outpatient, miscellaneous other services that are beyond the acute care setting. Participation in the Part B program is optional for beneficiaries after they meet Medicare eligibility. And so you see that there is a lower number of individuals that are enrolled in the Part B program than compared to the Part A program, so 62 million in 2024. Typically, most of these differences are for individuals that are continuing to work after they've reached Medicare eligibility, typically age 65. The way the Part B program is financed is and the funding levels are established annually. So there's a premium that's established, and that then determines how much general revenues are going to be contributed into the trust fund. In addition, there are some modest other amounts of revenue that are deposited into the program. But you can see here that this is over $550 billion in 2024. So it's actually quite noticeably larger than the Part A trust fund, which was not always the case. At this point, I'll note that the Part C program, the Medicare Advantage program, which individuals can enroll in lieu of receiving fee-for-service Part A and Part B coverage, that Part C benefit is funded through both the Parts A and Part B account, and so dollars come out of each trust fund for Part C beneficiaries. Lastly, the Part D account is the prescription drug program, also a voluntary program, and so similar to the Part B, not everyone that's eligible chooses to enroll. Many have coverage through either employers or other sources of drug coverage that limits the amount of individuals that end up enrolling in Part D, as in David, or drugs. The contributions, the income that comes into the trust fund is similar to Part B. It's largely beneficiary premiums and general revenue from the Treasury. In addition, there are some other items. State transfers is a significant portion as well, to account for what used to be a state responsibility through the Medicaid program for their dual beneficiaries. So that actually is a pretty significant portion of income coming in as well. But as you see there at the bottom, 80.9% of revenue is coming from federal government contribution. So that we are talking about a very significant portion is financed through just general revenues. Like to look at how the program has changed over an extended period of time. The trustees report includes a projection for the next 75 years. And I like to include this chart or this comparison just to show how much the program has changed in a much shorter period of time. And so if you go back 40 years, the program was predominantly an inpatient program. Medicare was predominantly provided inpatient services. Physician was another significant piece, and there was the other components were relatively small. And you can see as recently as 20 years, the program began to get more diverse, and the spending distribution has changed pretty significantly there. And if you look to 2024, we now can see effectively the private effects of Medicare. That roughly 2/3 of all Medicare dollars are provided through either a managed care organization for Part C coverage, or the private Part D plans. So those legacy fee-for-service programs are becoming a smaller and smaller portion of the ever-growing and significant Medicare pie. You can see across the bottom that Medicare as a share of GDP has increased pretty significantly, not surprisingly, and consistent with how the program was expected to evolve, both because of increased enrollment due to the baby boom generation becoming Medicare eligible, as well as healthcare costs increasing significantly faster than the general economy. So before I get into detailed evaluation of the projections, just want to put a rough sense of where the dollars are coming from. This includes the, since the inception of the program, and includes the full 75-year projection of the program. So you can really see how this is projected to change over time. You can see that those, starting from the bottom, those payroll taxes is generally a pretty stable portion. That 2.9% that is the current financing rate on payroll taxes, that is not scheduled to change. So that is relatively stable in terms of the share of the Medicare financing. You can see it does have somewhat of an increasing slope because, as I mentioned, that high income earners pay an additional share, additional tax into the trust fund. The fact that those thresholds for how high income is determined is not indexed, that is projected to be a growing share over time. Similarly, tax on OASDI benefits, that is also expected to have a growing share as more of that income is subject to taxation over time. You could see the next bar, the premiums that are paid for by beneficiaries, mostly in the Part B and Part D programs. As those programs become a growing share of the overall Medicare pie, the premiums become a growing share, as does the general revenue transfers, that large bluish gap that's that is the larger share, or the largest share of the Medicare financing. Not only is the largest share, but it's expected to grow faster than the other portions. The last bar on top there you can see is the deficit, and that's when we talk about the HI program, and when that trust fund becomes depleted, there is going to be insufficient income coming into the program to pay the full scheduled benefits. So what's presented here is the full scheduled benefits, but there is currently not the means for which those benefits to be funded under current law. And so we'll talk a little bit about that as we move through the presentations. The last thing I want to point out here is that this presents total expenditures as a share of GDP. You could see that, not surprisingly, this increases over time, but towards the end of the projections, you could see it actually levels off and even decreases somewhat. And this gets to the fact that is pointed out in the trustees' reports, is that there are certain elements of current law that may prove to be problematic for fully implementing as currently prescribed. The two that are noted in the reports are that physician payments are the updates for physician payments are scheduled indefinitely into the future, and those rates are significantly below the rates of inflation and amount of expected cost increases for physician practices. And so that will become an issue over time. And similarly, most non-physician payments are updated or have an offset to the update for economy-wide productivity. Economy-wide productivity is generally higher than what has been experienced by healthcare providers. And so to the extent that healthcare providers can't match the economy-wide productivity, that will also put growing strain on providers, as their payments might not be keeping up with their costs. And we'll talk about that in a little bit when we talk about when I mentioned the illustrative alternative scenarios. But let's jump into the key results of the report. And the key result that typically gets the most attention is the trust fund depletion date for the hospital insurance trust fund. And this year's report, it is projected to be in 2033. And this is 3 years earlier than in last year's report. The actual balance is a deficit, so it is negative 0.42% of taxable payroll. This is worse than the 0.35% of taxable payroll in last year's report. The way to think about what this actuarial balance represents is the 2.9% of payroll, the tax rate that's currently implemented for payroll taxes, that it's currently 2.9%. If that was increased by 0.42% or was increased to 3.32%, then the trust fund would be in full actuarial balance for the entire 75-year projection. So why did the Hospital Insurance Trust Fund see a slight deterioration from last year's report? On the A side, so this was because of higher inpatient and hospice spending projections. We noticed in 2024 in particular that there was an increase in utilization, and we'll talk a little bit about that when we get into some of the more details. Similarly, just to kind of provide an overview to what the Part B and Part D experiences as well. Part B also had higher spending, most notably for outpatient hospital and for physician-administered drugs. On Part D, we were actually having somewhat lower projections. There's actually a little more complicated story to this one, but generally the projections are lower in this year's report than in last year's. And the key reason why it's lower is because there's lower projected enrollment and disproportionately lower enrollment for those that are eligible for low-income subsidies, where there is a greater proportion of federal spending for those beneficiaries. So now looking at HI, and I'm going to try to move something that's blocking my screen. So looking at HI spending mostly over the short term here, that how does the near-term experience from this year's report compared to the prior report? And you can see that in the solid line in 2024, spending was clearly higher than what was projected in last year's report. Building off of that higher experience, the trustees have a slightly faster growth in spending for the next several years for, in particular, inpatient and hospice spending. And so that gap widens a little bit as you move on for the next couple of years. And then by the end of this very short period, those lines start to kind of move in parallel. They actually get more narrower as we look into a longer period. But basically, the near-term experience is higher than expected. We're basically starting to see increases in utilization. And if you look at the early years, so you can see from 2019 to 2022, period that was entirely impacted by all of the COVID experience. And the only reason why there was that noticeable bump up in 2020 wasn't with respect to utilization of hospitals, HI services. It was due to the Accelerated Advance Payment Program that got money to these organizations as utilization decreased substantially. And so you can kind of see this odd pattern of a lot of dollars came out of the trust fund in 2020, not related to utilization. Then those monies started getting paid back in 2021 and 2022 as utilization started to return to somewhat more typical levels. And then that phenomenon pretty much was done mostly in 2023 and certainly into 2024. But throughout that period, there was just low utilization of, in particular, inpatient hospitals. Started to tick up back to typical levels in 2023, and then it actually ramped up and was faster than historical levels in 2024. It's too early to say whether that is just a phenomenon of effectively deferred use, that those services that people did not go to the hospital for, and they just delayed getting that care, and it's starting to show up in 2024, or is there? And so if that's the case, if it's just truly a timing effect, we would expect that to wane over time, and grow more typically thereafter. It also could be that there is just a shift in how care is being provided, and it's a little too early to kind of have a firm opinion as to where that will eventually settle out. Moving forward, so this looks at the trust fund ratio. So this is how much dollars are in the trust fund at the beginning of the year as compared to how much is going to be expended the next year. And you can see over time this has been fairly stable. You can see 2010, shortly after the financial crisis of 2008. And the starting of the massive retirement of the baby boom generation, this ratio decreased pretty substantially. You can see that it kind of leveled off somewhat in that COVID period, but it is expected to continue to decline until trust fund depletion. And you can see how that trajectory looks a little different in this year's report in the solid black line, as compared to the dashed line in last year's report. And again, that is mostly due, almost entirely due to the higher utilization of services that's expected in this year's report. We'll talk a little bit more about some of the broader categories of what's affected this over time a little later. Looking at the just key measure, the comparison of that development of that actuarial balance. It is the difference between how much money is coming into the trust fund versus how much is going out, comparing that income rate compared to the cost rate. And you can see the income rate generally stays pretty stable over time. The largest component of that income rate is the 2.9% payroll tax level that doesn't change over time. So the income rate generally stays pretty stable year to year. The cost rate, you can see, is higher in this year's report, and that is what's driving that increase in the actuarial balance. Looking at the longer term and that comparison of, it's probably not the best use of color here, in that the lines all look the same, but you can see that bottom line, that current law income rate, that's how, that's that the measure of how much income is coming into the trust funds. You can see the lines on the top, the dashed line being last year's projection, and the solid line being this year's projection. You can see that those lines generally both converge to the income rate over the the extended period of the projection period, and that largely is due to those productivity differences that I was mentioning earlier. So the fact that the updates are projected to increase at a slower rate than how much provider costs are expected to increase, that truly determines, that truly drives how these costs tend to converge over time. Looking at what it would be if, instead of using the current law updates, if we were to use something close to what's in the illustrative alternative scenario, is what using a productivity offset that would be comparable to what we think would happen on the private side, which is effectively what we think is achievable productivity, or historically achievable productivity for the health sector. To put numbers around this, the economy-wide productivity in the long range is projected to increase by about 1% per year. We think healthcare productivity tends to have averaged around 0.4% over year. And so what you can see in the gap between that top black lines and that red line is effectively that cumulative effect of that 0.6% differential. 0.6% is not a big difference when you're looking, 1 or 2 or even 5 years out. But when you look out 75 years, it truly does accumulate pretty significantly. Looking at Part B, here we can see that a 2024 experience came in notably higher than what was projected, and that's generally expected to continue throughout the entire projection period. You can see that those rates, comparing the current report, are both in the historical period, which most of the historical period didn't change that much, yet the comparison to the prior report is actually pretty significantly different. That 7.7% for that period in last year's report versus 8.4 truly illustrates how much recent experience has been pushed up on the Part B side. And that is largely due to additional spending around physician-administered drugs, or at least what's considered physician-administered drugs. Those differences are expected to continue somewhat into the future, but the projection factors generally are pretty consistent with what was in the prior report. On the Part D side, there's a lot happening here. 2024 did not come in much different than projected, but you can see the projections moving forward are notably different and have a peculiar pattern to them. That peculiar pattern is that in last year's trustees report, it was not anticipated that there would be a Part D demonstration that would effectively provide for additional federal contributions into the Part D program. So that happened. That demonstration is not projected to have as material an effect in 2026. So you can see that contributes to that wave factor there. It's hard to see here, but in the long run, beyond these 5-year projections, Part D spending is notably lower than what it is in the current report. And that, I think I mentioned already, is due to lower enrollment generally, but more specifically lower enrollment for that low-income subsidy population. Really see that here. Starting with the Part B side, there is a substantial increase in the long-range share of GDP projections. On the Part B as in boy side, that is because not just is an increase in physician-administered drug spending significantly increasing costs, which it does, but that is one of those categories that is not affected by productivity offsets. And so that is, in the long run, the fastest growing category. And so now we have more spending in that faster growing category, which leads to the higher projected spending there. On the Part D side, you can see in the 2098 GDP going from 0.69 down to 0.64. That is the effect of that lower enrollment effects. What could get some attention this year is the fact that Part B spending is higher. That will translate into a higher projected Part B premium. And you can see in this year's trustees report that Part B premium is projected to increase pretty substantially from the 185 currently to the 206.50 for 2026 in this year's report. This amount is not finalized until the fall, and so we'll see where that ultimately shakes out. But you can see that that increased spending in 2024 and into 2025 is putting some upward pressure on Part B premiums. The Part D premiums are affected by a number of factors, and so this base beneficiary premium here that is not all that influential in terms of how the premium is actually going to be that individuals are going to see next year. Okay, just taking a step back for a moment, you can see how at the beginning of the pandemic, it was basically on a pre-pandemic level, which was the last pre-pandemic report was in 2020. All the information was finalized before March of 2020. The expectation then was that the HI depletion would be in 2026. And you can see that that has increased somewhat, pretty significantly over a number of reports that were released. This year we have that turning around somewhat, again, due to that increased expenditures in this year's report compared to last year's report. Wanted to just take a step back to show why that is. And you can see this is the expenditure projections comparing the 2020 report to the 2025. And you can see there's a lot of noise around the pandemic period. And we've got a number of years where we're currently projected to have higher spending than, where we had lower spending than what was projected in 2020. By the end of the period, given that the economy has been growing pretty faster than was expected in the 2020 report, we're expected to have some faster updates. And the net effect of this is that the expenditure projections between these two reports, the 2020 and the 2025 report, is virtually nothing. So it's we're now projecting to be 0.23% lower than over this roughly 15-year period. As compared to income projections, where the income projections are just generally and almost exclusively higher than what was projected in that 2020 report. And so you can see that the total amount of income that was coming into the trust fund is roughly 11.3% higher than what was projected in the 2020 report. And that effectively is the exclusive reason why the trust fund depletion date isn't 2026 that was projected in that 2020 report, and is now at 2033. It's almost exclusively an income story. I have a feeling the discussion around the release of the trustees report would have been very different if here in 2025 we were talking about trust fund depletion date of 2026, but we're not. We're talking about trust fund depletion of 2033 in this year's report. The last thing that I wanted to talk about is that some may be familiar that the trustees are not the only ones that project out the depletion dates of trust funds. CBO releases a long-term budget projection each year. And in this March, they released their updated HI depletion date of 2052. And that raised some eyebrows, certainly mine. It was 17 years later than their projection that they had in last year's report, which had a depletion date of 2035. They made a few technical and economic changes that contributed to their substantial difference between their 2024 and 2025 projections. But taking a step back and wanting to kind of look at the latest estimates from both the trustees and CBO, and so what's accounting for that's almost 2-decade different in HI depletion date, and just focused on the period 2024 to 2034. The trustees are projecting 1% less in income coming in, so less dollars coming in, but more importantly, 9% more spending going out the door. And we can at least unpack a couple of pieces to kind of help explain that. One is that the trustees just have the ability to incorporate more recent experience. And so the effects that I was mentioning earlier in the presentation about how 2024 spending on the HI side came in higher than anticipated, that is not something that CBO had the opportunity to kind of have insight into. That leading to higher spending for the Medicare Advantage program that was announced in April of this year is just something that's not that wasn't able to be incorporated into CBO. But it's not just the experience. The trustees have faster spending growth projections as well, just slightly. So I think roughly almost half the difference in the spending can be accounted to you know the trustees changing their assumptions versus CBO changing theirs. And so what looks to be a striking difference between the two projections, when you kind of unpack things a little bit, there's a little bit of more commonality between the two. I'm not going to forecast what CBO is going to do, but I would anticipate that to the extent that they incorporated higher experience than they might have been projecting, then that would perhaps narrow the gap between these two projections at some point. When they update their analysis and release their next report. But I would not expect that to account for all of the differences either. With that, I am going to turn it back over to Mark and look forward to the rest of the discussion.
Thank you very much, Paul, for an excellent presentation. We learned a lot, both about the Medicare program and its finances and the projections of such. So now I will turn it over to our panelists, starting with Joe Antos to offer some observations, comments, and maybe a little bit of policy discussion. You need to remove your mute.
You mean you can't read my lips? Thanks, Mark, and thanks, Paul Spitalnic, for many years of hard labor. The trustees report is probably the most visible aspect of your job, but you have a lot more work than that on a minute-by-minute basis. So the public should appreciate that. At least the public that is viewing this event. Now, the trustees report is obviously a very technical document, but it's also a political document. And certainly the release of the trustees report is a political event. It's not surprising that we regularly do not get the report released in early April, which is the statutory date for releasing the report. It usually comes out later. There may be technical reasons, but one solid political reason is that if you have bad news as a political person, that's not Paul Spitalnic, by the way, that really refers to political appointees in every administration, Republican or Democrat alike. You really don't want to release bad news if it's going to get in the way of something else you're working on legislatively or in some other fashion. So releasing it the day before a federal holiday is, I think that is the ideal release date. And I think we've seen that pretty regularly over the last few years. Anyway, so kudos to those who arranged that. I make a general comment about what I think are disturbing parallels between many of the aspects of the trustees report and the sort of the mechanics of how the trustees report is used, and broader legislative and fiscal issues that are active today. And there are a couple of points that I think are worth observing. First of all, thinking about the reconciliation bill that is now under consideration, there's a big debate over CBO scoring, and the major aspect of that is will CBO or will Congress accept CBO's standard scoring, which is current law, or will they tell CBO to score the reconciliation bill on the basis of current policy? If you use current policy, then the tax cuts look like they don't add anything to the debt and deficit over the next 10 years. If you use current law, then since the tax cuts expire this year, then extending the tax cuts adds some loss of revenue. In other words, it makes the debt deficit situation worse. The trustees report actually, or the actuary's office actually has this comparable set of decisions. The trustees report is essentially current law, more or less, but essentially current law. And then the excellent supplementary report that has been put out for, I think, 11 or 12 years now, the illustrative alternative scenario. In a sense, that's has an aspect of current policy. Now, it's not really current policy, but it makes somewhat different assumptions about the growth of spending in Part A and Part HI and SMI, the two trust funds, that I tend to agree with that analysis. I think that is a more realistic expectation of what it's going to take to maintain some degree of access to medical services in the Medicare program over time. If we continue on with current law, we're going to see major cuts, and that's going to cause some real risk to patient access to services. And then the Medicare funding warning. The Medicare funding warning is the idea behind it is that if there's an excessive amount of general revenues that's going in to support Medicare funding, that is a sign that Congress should really look at the program and try to deal with either the spending side or the revenue side to get the trust fund more in balance over the long term. This year is the 8th consecutive year that the Medicare funding warning has been issued. The funding warning is supposed to trigger actions that ultimately could lead to legislation. It hasn't for 7 consecutive years. Seems unlikely that that record will be broken. So in essence, Congress ignores it. The comparable on the fiscal side is the debt limit. Now, Congress can't ignore the debt limit, but what it typically does is, and oftentimes waiting till the last possible day, they increase the debt limit. And so in that sense, unfortunately, from a fiscally conservative standpoint, we have two mechanisms here that are not doing what people might have imagined or might have hoped for, which is to spur responsible congressional action related to, in the case of Medicare, either spending or revenues. So then finally, what all this means is that Congress is generally slow to act on both Medicare funding issues and Medicare spending issues, and also on broader fiscal problems. And if one were to look at the HI insolvency date, but slightly differently from Paul's slide, and unfortunately, I do not have a slide for this, but if you were to look at how many years before the HI trust fund is deemed insolvent, you look at the time series, what you see is that number is years of, let me call it grace, fiscal grace, bumps around a lot. But I tend to focus on the year 1997. 1997, Congress passed the Balanced Budget Act, which resulted in substantial reductions in the short term for Medicare spending. What spurred that? Well, it may have had something to do with the number of years to trust fund insolvency, but maybe not, because in 1997, the trustees report said that there were 4 years. Well, in 1993, which was 4 years before that, it was 6 years. And basically, it was a low number of years for 5 or 6 years of trustees report before Congress got around to saying, well, maybe we ought to do something. That's a sign of let's say the political challenges of dealing with reality, and that's trouble as we go along. Not so much for the baby boomers, but it's going to be real trouble for our children and our grandchildren who are going to be stuck footing the bill and dealing with challenges in healthcare. So so the big question, I think, is, well, why can't we do something about it? I regularly run into people who say, well, Medicare, it dominates the health sector. So why can't Medicare solve this problem? And it's true. Private insurance doesn't model itself after Medicare, but basically adopts and adapts to all of Medicare's policies. Obviously, all the coding systems that Medicare uses are used by, and reasonably so, are used by all other insurers in the United States. And many of the other processes that Medicare uses to manage the health delivery aspects of the program are also adopted by private insurers. So why can't Medicare just tell them what to do, or why can't they change it? Well, there are two reasons for that. One is that, of course, you have to have a better idea, and that's always hard to come up with. But maybe a more fundamental issue is that just as Medicare has captured the private insurance market, Medicare is itself captured by the private insurance market. In other words, we have a system that is so directly and intimately interconnected that it's going to require both the Medicare program and the private insurance program and all of the major health systems to move in a direction that promotes more productivity in healthcare. That's the real solution to our financing problems in not just Medicare, but more broadly. And that's a big push. I could say a few things about things that could be done in Medicare, but I may have used up my time. I'm not entirely sure.
Thank you. Thank you very much, Joe. And now we'll turn it over to Paul Ginsburg.
Well, thank you very much. And I'm really pleased to have been invited to serve on this panel. I've served on this panel before. I decided to look into my files to see when it was and what I said. And I found that, yes, I was a panelist in 2014, probably with both Joe and Paul Spitalnic. And I made two major points in 2014. The first focused on challenges in forecasting spending when recent trends are above or below prior forecasts. That was a big issue in 2014 when there had been a sharp slowdown in the spending trend. And in 2015, we're seeing a moderate uptick in trends, which Paul Spitalnic has talked to you about. Now, problems for the Medicare trustees or the actuary when prior legislation to slow spending growth is realistically unachievable. In 2014, it was the sustainable growth rate formula, for those who remember it, the way of updating physician payment rates. And in that case, the actuary's current law assumption, their main projection, departed from assuming that the payment rate cuts prescribed by the SGR formula would be implemented. And the reason was because rate cuts called for in the past had consistently been deferred. So in a sense, the actuary interpreted Yes, the legislation says this, but that's not really current law because they never follow it. Maybe Joe would have called that a current policy. In this year's report, Paul Spitalnic has singled out two aspects of current law. One is the lack of an update to physician payment rates to offset inflation. And the other is requiring that hospitals and other providers achieve productivity gains equal to those of the economy as a whole, rather than those experienced in healthcare services delivery consistently lower. He mentioned at this point 1% annual gains in the economy, 0.4% in healthcare. Now, since these two policies have been consistently implemented to date, the lack of sustainability of these policies has not been reflected in the current law projection, but it is a key basis for this year's illustrious alternative. And to me, the latter is extremely important because ultimately Congress will revise those provisions of legislation to increase payment rates because current law, as Paul mentioned, is just not sustainable. And at this point, I would advise policymakers to pay a lot more attention to this alternative projection than to the current law projection. Now, this year's trustees report projects exhaustion of the trust fund 3 years earlier than previous year's report, which means we're now 8 years off instead of 12 years off. It should be forcing policymakers to take a serious look at cost containments or revenue enhancements in the Medicare program, something that has not happened for some time. And I'm not sure that it will happen at this point. It's pretty clear that opportunities to slow spending growth by cutting provider payment rates are quite limited because past cuts have left them very low. In its March 2025 report to Congress, MedPAC recommended increases in payment rates for hospitals and physicians, increases exceeding those in current law. But MedPAC did recommend cuts to rates for inpatient rehabilitation services, home health services, and skilled nursing services, as well as keeping rates for hospice care unchanged. Congress should start by at least taking these actions. But it's clear that substantial reductions in expenditure growth are going to require changes in the way that medical services are delivered, such as more effective management of chronic disease, reduction in low-value care, and more effective coordination of care. And I see two major opportunities to achieve substantial reductions in Medicare expenditure growth. Indeed, both of them have had bipartisan support. We've seen expansion over many years now in payment approaches that seek to reduce the role of fee-for-service and increase the role that capitation and payment for episodes of care play. While there have been some successes, the savings to the trust funds have been small. And whether on the basis of statutory authority, such as accountable care organizations, or experimental authority through the CMS's Innovation Center, the mindset in pursuing these payment reforms has been continuous experimentation, typically with volunteer organizations, as opposed to simply implementing a broad change in payment strategy. Now, after well over a decade of experimentation, it's time to decide which approaches are best and make them mandatory, or in some cases, simply initiate lower payment rates for those providers not participating. We've learned enough to do this effectively and can also revise things as we proceed. Recall that the major payment reforms in the past, inpatient hospital prospective payments in other segments such as hospital outpatient care, and the Medicare physician fee schedule were implemented without decades of prior experimentation. There was virtually none. The second area of reform is Medicare Advantage. Medicare Advantage has been very successful in that more than half of those with Part A and Part B coverage are enrolled in Medicare Advantage. I think MedPAC indicated 54% now in 2025. And it has appeared that Medicare Advantage plans have lower costs than traditional Medicare, although MedPAC recently showed that after adjustment for favorable selection and differences in coding practices, Medicare Advantage plans are about 100% of spending in traditional Medicare. Since 1985, when private plans were introduced into Medicare on a permanent basis, Medicare has consistently spent substantially more than it does for comparable beneficiaries in traditional Medicare. So according to MedPAC, in 2025, CMS will spend 20% more for those enrolled in Medicare Advantage than if they were instead enrolled in traditional Medicare. This is $84 billion in 1 year. Overpayment depletes the trust funds, and it increases beneficiary premiums for Part B. Overpayment is due to combination of shortcomings in the approaches used to risk adjust payments to MA plans, as well as deliberate policies to increase payments, policies that have long outlived whatever usefulness they may have had. Let me talk about favorable selection. After risk adjustment, those enrolling in Medicare Advantage have consistently used less care prior to enrollment than those remaining in traditional Medicare. Indeed, favorable selection is highest among those with the highest risk scores. This likely reflects both steps taken by MA plans to be more attractive to those using less care than average, for example, offering often more extensive primary care, as well as choices made by beneficiaries, where those most likely to need substantial medical care, especially specialized medical care, find MA plans less attractive than traditional Medicare. Risk adjustment. More diagnoses not related to treatments are recorded for MA enrollees than for other patients. Incentives in traditional Medicare are for physicians to include only enough in the way of diagnostic information to ensure that they get paid for the services that they're providing, while MA plans encourage and support physicians to list more diagnoses because the plans get paid more. CMS has recently made some valuable changes in its risk adjustment system by removing codes that predict little in the way of higher spending, but a lot more needs to be done. The two policies that were deliberate, one is quality bonuses. This was an attempt to improve plan quality, which did lead to higher scores, though there have been some concerns about whether the measures actually reflect important aspects of quality. Is this program still needed? And if so, shouldn't it be budget neutral, like all of Medicare's quality incentive programs for providers? Benchmarks are well over 100% of traditional Medicare per capita spending in those counties with the lowest spending in traditional Medicare. Many of these counties now have large Medicare Advantage enrollment shares. Should we continue to encourage those living in areas where spending is low to opt instead for much more expensive Medicare Advantage plans? This is not the place to get into the weeds on Medicare Advantage payment reform. My point is that Medicare desperately needs to slow spending growth, and Medicare Advantage is where the greatest potential lies. Thank you very much.
Thank you very much, Paul. Now I'll open up to questions and remind the audience to send questions into Jordan, jordan.law, L-I-A-W, @aei.org. But I will start the questions. And actually, it is very much on the theme of the Medicare Advantage. So This really is addressed to Paul Spitalnic. It's a question about the assumptions that he makes about MA enrollment in the trustees report. So as I read the report, you currently have about 51%, a little more than 51% currently enrolled in MA plans, and that goes up to 58% over the next, I think, about 10 years. But then it's flat afterwards. It remains at 58%. And so my question is, why do you make that assumption, given that trends are that the enrollment in MA plans they continue to grow? And then, and actually totally related to the discussion that Paul Ginsburg just mentioned is that that presumably that has an implication for the cost of the program and the projections of the program. And I'm wondering if you could talk a little bit more about what those implications are. And as a sub question, this is maybe getting a little more into the weeds, but again, in the trustees report, you noted particularly large growth in the SNP population, the special needs population, which I think Paul Ginsburg alluded to. And if you could talk a little bit about that as to what's going on there, what assumptions you make for that, and what is the significance of that growth?
Thanks, Mark. There's a lot there, so I'll do my best to respond to all of it, and you can hold me accountable for what I don't. So the general question is to how are the MA in participation assumptions projected out? So you are correct. There has been a significant increase over time with respect to growth in the Medicare Advantage enrollment. The analysis that we do in order to kind of forecast that out is actually pretty detailed. And when you break things down into different characteristics. So for example, those that either have very high rates of penetration today or over time and see the trajectory of how are those rates changing over time as compared to areas that have had very low levels of penetration. And what we've seen is that the degree of increase in penetration rates in those very MA-centric areas has been quite slower than what it's been more broadly. And so that contributes to our conclusion or our assumption that there is a natural maximum amount of where enrollment could be in any particular county. That there is just some segment of the population that will not enroll in a Medicare Advantage organization. And so it clearly changes over time, and clearly there's some degree of variation there. But there seems to be some almost natural maximum of what that penetration rates can be. And so where we've seen some of those increases, and actually I'll try to connect the two questions, or at least what I'm going to take apart of your two connections. When we do that analysis, we look at it separately for the general enrollment, Medicare Advantage enrollment as separate from those that are in the special needs programs. Those in the special needs programs often are either one of two categories. One, they have a particularly chronic condition. That's one that doesn't have as much growth in it, but the one that has had significant growth is the one with a dual eligible special needs program. So those that are eligible for both Medicare and Medicaid. And so now I'm going to tie the two pieces together. Where we have seen significant growth. So while the general enrollment has had these kind of natural limits to them, and where there's been some faster growth in some of the lower enrollment areas, it generally has been slowing down. Where the significant increases in enrollment have been more recently have been in with respect to these dual eligible special needs programs. And I'm going to try to tie this back to some of the things that Paul Ginsburg was alluding to, is that Medicare Advantage provides a pretty good deal. And if you kind of rely on the MedPAC analysis, and you would say, well, if I can get if I as a state could get my Medicaid dual population enrolled in some of these dual SNP plans, perhaps I can get access to that 20%. If that 20% is the right number. That will reduce some of my state spending if I can do that. And so that's what we have seen. We have seen that those increases in those dual plans recently. And when you're talking about getting those dual enrollees enrolled into Medicare Advantage, to the extent that you have more and more states joining, that's just there's a natural limit there, that we can only have 50 states plus so many territories have their programs shift over to Medicare Advantage. And what we've seen is most of them have already done so. And so, yes, we do have some increases continue on. We have seen some stability in that overall Medicare Advantage enrollment penetration rates. More recently, there's been less fluctuation in the last, say 2 or 3 years. We saw some pretty significant increases, in particular around the dual SNPs, in the early 2020s. But the last couple of years, that enrollment growth has stabilized somewhat. We don't think it's going to go to zero just yet. We do think there's more room to grow. But for those two factors, the natural limiting of how many beneficiaries are going to enroll on Medicare Advantage, in a particular area, as well as the limiting of the number of new SNP enrollments that are going to come through, mostly from the dual population. That's just going to have to slow down, because most of them or many of them are already there, and it's going to be harder to get even more so. So that's the reason why we have the increases in Medicare Advantage overall enrollment, flattening out over time and eventually getting to a stable level. Before I turn it back to you, I have to, and I apologize for interjecting, but there was two things that Joe started with that I feel obligated to respond to. In my role as chief actuary, and in the ability to craft a very specific actuarial opinion at the end of it, I work very hard to make sure that the trustees report is not a political document, that it is as objective a document, an assessment of the Medicare finances as is humanly or as to the best of my ability as possible. So I will push back on the political document nature of the trustees report, that this is as objective a technical document as I could possibly make it. And I'll give you a second. I'll go. I promise I will give you the opportunity to respond. The second one is just on the release date. And the release date, yes, the release date has rarely been April, the statutory date of April 1st. This year there was, in an unusual course of events, there was actual significant legislation that affected the old age and survivor Social Security program. And so incorporating that caused a delay to get it into, caused at least a couple of month delay. And then the ability to get everyone into the same room to get these reports finalized. I think you might have read more into it than perhaps warranted. It is a challenging exercise to get several cabinet members and and chief actuaries into a room. So I would not read anything into the fact that it was released on the day before a federal holiday, but you are free to read into what you like.
Well,
So,
thank you, Paul. Yeah, what you produce is a technical document. What's done with it, and in fact, how it is released is a political event. There's no question about that. Point number one. Point number two, if we just look back, I didn't bother to do this because it seemed like a waste of time. But if you look back on previous release dates, there is a surprising number of releases that occur on a Friday morning, knowing that at least in the old days, reporters basically weren't working Friday afternoon. So take that as you will. This was not a criticism of the actuary's office, or certainly not of you, Paul. You're doing God's work, and it's the rest of the system that may be getting in the way.
Thank you, and thank you, Paul, for answering my question. I think I now have a better understanding of those assumptions. I'll invite the panelists. Joe cut off a little early in his remarks, so if he wants to take a little bit more time to talk about the healthcare system in general, I think this might be a good time. And then Paul Ginsburg, if you want to make any further questions or comments, please do so. Ask Paul Spitalnic what you would like. So let me first give it back to Joe.
Thanks, Mark. Yeah, I did want to make a few comments. Paul's comments were, I by and large agree with the specific points that he made about changes that could improve the Medicare Advantage program and Medicare in general. A point that I would make is that we don't really have and we have never really had in Medicare Advantage or in the precursors, Medicare Plus Choice, and then before that there was no real name to it. But we've had options that were outside of traditional Medicare since sometime in the early 80s. And the fact is that we don't really have competition there. So instead of going back to the ancient history, let's just talk about Medicare Advantage. We don't really have full competition for a couple of reasons. Yes, there are bids, of course. But the problem is that everything is tied to fee for service, and in the case of Medicare Advantage, with plus ups. So in fact, if we had what has been called premium support, which is a more fulsome competitive program with the plans actually bidding against each other, but also bidding against fee for service, and with fee for service actually developing its own bids on a regional or market basis. That would spur some competition. In order to do that, of course, you'd want to see some standardization of benefits in the Medicare Advantage program. You'd want to do that for a couple of reasons. One is that in many ways, Medicare Advantage is almost as confusing as traditional Medicare. MA doesn't have the challenge of trying to understand what you should do about supplemental coverage, Medigap. That's a unique problem to the traditional program, and it confuses, I think, everyone who enters the Medicare program at age 65. But nonetheless, there are a whole host of additional benefits beyond the one that everybody wants, which is either eliminating or reducing direct out-of-pocket costs, Part B premiums, and maybe lower cost-sharing amounts. But beyond that, there are a whole bunch of things that Medicare Advantage plans offer that I think arguably are not probably high priority in terms of most people's health care. But they because of the peculiarities of our bidding system, they uh, do ultimately add cost to the program, which of course the taxpayer is sharing in. And also, the beneficiaries in many ways, they don't realize it. They're sharing in it in the sense that at least future beneficiaries are going to see higher payroll taxes, and current beneficiaries are going to see it because there is inevitably a steady pressure upward in all insurance premiums and in Medicare. That's partly driven by the fact that there are these marketing opportunities that have to be paid for in one way or another. So there's a lot to be done that could be done, but very difficult to do. One more thing about risk adjustment. There's a lot of criticism about risk adjustment. I think it's well deserved. But if we had full competition, you'd need a good risk adjuster, because what we don't want is for Medicare Advantage plans or private plans competing. Let me not say Medicare Advantage plans. We don't want competing private plans to be able to avoid high cost patients. And I believe that there would always be kind of a fallback, let me call it a revised or reformed traditional Medicare program. So it's really, again, that's an issue on the private plan side. And so risk adjustment is a very, very difficult problem. We need to do better on this. We need to continue to work on it. I think it's critically important. Thank you.
Sure, I have some thoughts.
Go ahead.
First of all, as far as I also, like Joe, believe that the path forward on Medicare Advantage is to make it a more competitive market. But I don't advocate premium supports, if only because until we can fix the risk adjustment issue, premium support would be devastating for people who want to continue in traditional Medicare. Just think of it. If Medicare Advantage is 20% overpaid and we have real competition, then you'll have to pay an extra 20% to stay in traditional Medicare. So that's not going to work. What I've tried to do, as some others have come up with a little more awkward, but ways in which you could have competitive bidding in Medicare Advantage, but not go to full premium support, not involve the determination of what beneficiaries pay to remain in traditional Medicare. And there's a lot that you can do. And our country has had some real experience in steps that increase competition in health insurance. Think of the insurance purchased on the marketplaces through the Affordable Care Act, that plans have to be have one of four actuarial values, bronze, silver, gold, or platinum. That makes comparison of plans far more easier. California, through its exchange called Covered California, has gone even further of actually specifying the benefit design. Now, presumably, that's not good for innovation, but it means that consumers can truly focus on networks, service, and price. And it just makes the choice a lot easier for them. So I think there's a lot more that could be done. And as Joe said, standardizing benefit designs. What you could do in Medicare Advantage is have a basic benefit design, a premium benefit design, and maybe even a super premium, but 2 or 3 rather than hundreds that you have today. And beneficiaries really don't need to choose among 43 offerings in their location. We know from behavioral economics research that people do best when they have more limited numbers of choices. So there's a lot more can be done. Paul Spitalnic got me thinking about what is the future for Medicare Advantage market share, and I suspect it's not going to go much higher. I think one of the reasons is that the overpayment is so large now, and the federal budget pressures are becoming so strong, especially if the reconciliation bill passes and increases the debt much further. I think it's inevitable that Congress and CMS are going to be more diligent in reducing the overpayments. And I think it's the overpayment that has driven a lot of the market share, as Paul really nicely explained, and the growth of SNPs for Medicare and Medicaid dual eligibles. I think that, and insurers are groaning about the changes in risk adjustment that CMS has implemented over a 3-year period, and where both the Biden administration and the Trump administration supported that and let the full 3-year phasing go into effect. I think we may be near the peak now.
All right, thank you. We have actually 2 questions from the audience. We have 10 minutes left in our discussion. So let me read the questions from the audience. I think they are both to Paul Spitalnic. So one is, I think, very straightforward. What increase in the contribution rate would extend the HI's trust fund solvency for the next 75 years?
So that that actuarial deficit number that was calculated, so the one that went from 0.35 last year to 0.42 this year, that 0.42 is what would need to be added to payroll taxes to narrow that deficit down. So if the 2.9% payroll tax rate was increased to 3.32%, that would narrow the 75% actuarial deficit. It's also included in the report that if instead of increasing taxes, instead of increasing the payroll tax, if you were to work on the benefit side, if you had an immediate reduction of 9% off of all benefit expenditures from now through the next 75 years, that would also eliminate that long range actuarial deficit.
Thank you. That's an excellent answer to the question. Next question is sort of a couple of parts, a little more complicated. So I'll just read it. Would you talk in more detail about what is driving estimated accelerated increase Medicare Part D drug spending? I assume in light of the IRA, that's legislation, inflation cap, and Part B drugs in 2028 being subject to price negotiation, that the acceleration is due to the expectation of introduction in the US of new Part B drugs with increasing launch prices. That's a question. I'm sure there's a lot going on there. Also, how might your assumptions about Part B drug spending be affected if the administration required most favored nation pricing for Part B drugs? Well, a lot of going on in that question.
Okay, well, on the drug spending, so in particular noted that, why is Part B spending up in this year's report compared to last year's report? One of the key factors that stood out was that increased spending for what's considered physician-administered drugs. So those are not the drugs you get at pharmacies, but drugs you get in other sources, either in a physician's office, perhaps in a hospital setting. So what we've seen there, and this has gotten a fair amount of attention in broader press as well, something that I didn't hear of 2 years ago. 2 years ago, I never heard of the notion of skin substitutes. It's just not something that was on the radar screen. However, I think I'm going to get this not exactly precisely, but I think in roughly 2021, Medicare spent something like $700 million on these $800 million on these skin substitutes. In 2024, spent something like 7.8 billion. 2021, 700 million, 800 million. 2024, 7.8 billion. these are new products that they're not new products, but the new products that have been introduced here have just been extraordinarily expensive and they've been widely used. So this is something that there's been proposed rulemaking around this. I would certainly expect to see some attempts to try to control this spending into the future, but those drugs in particular were ones that stood out. But generally speaking, when you're talking about Part B or physician-administered drugs, these are typically things like cancer drugs, oncology drugs. And to the extent that there are new innovations in this area, they are typically extremely expensive. And so the question alluded to, well, what about the effects of some of the IRA negotiation provisions? Well, first, the effects of the IRA negotiation provisions were estimated last year, so we already had built the savings in for that. But generally, what it takes for a drug to become negotiated, it's not going to be when that drug is newly released and is just getting Medicare covered. It needs to be a high Medicare spending drug in order to get onto the list of considered to even be considered for negotiations. So I think the question correctly alluded to, some of these newer, higher cost drugs are going to be newer and higher cost for some period of time until those negotiation provisions would otherwise apply. So that's the general answer to the first portion of the question. The second question on most favored nation spending, do not have any specific estimates, mostly because it is often difficult to quantify what most favored nation specifically means. So are you taking from a list of 10 countries? Are you taking the lowest of the 10 countries? Are you taking all OECD? Or so it is often a challenging proposal to estimate, just because the specifics are often really important to kind of work out those details.
All right, thank you. I'll take the moderator's prerogative to ask the last question, and then we'll give each panelist and Paul, the opportunity to make a couple of closing remarks. So my question is as follows: there's been no technical panel from the Medicare assumptions since 2017. They used to be about every 4 years, so it's been some time. So there's been no opportunity to revisit the factors model, which is what is used for projecting healthcare costs for the economy as a whole, since that time. And that factors model assumes that the healthcare sector has no impact on GDP, even though, as we've discussed really quite extensively today, that the healthcare sector is much less productive than the rest of the economy. So given that healthcare now is about 18% of GDP, and as I understand the implied projection, it's not in the trustees report, but in other documents that CMS produces, it's over this long horizon, it's expected to go up to about a third of GDP. Does it make sense to take maybe more of a holistic approach where we model the effect of healthcare on the economy, and as well as in both directions? In other words, the effect of the economy on healthcare demand and supply, but also the nature of production of healthcare in terms of how that flows through economic growth and productivity in the economy. As you know, I do have such a model. It's a two-sector, two-factor model. And I invite, I guess, Paul Spitalnic in particular to sort of just comment. Maybe I don't want to put him on the spot, but more broadly in terms of is it time to sort of revisit the general way in which healthcare is modeled for the trustees report, and this is important for policy analysis. Obviously, that's the whole nature of the game.
So certainly welcome additional work in this space because there are not many forecasters out there looking at 75-year projections of how healthcare spending is going to evolve over time. And certainly welcome additional contributions. And so thank you for doing work in this area. I think the work that the Office of the Actuary has done in support of the Board of Trustees is pretty solid in terms of the analysis and in terms of the way that factors model has been developed and evaluated and updated over time. And there's been work. There's been work on the factors model since those original papers that you referenced. Whether an additional model would produce better results, I mean, it's often a subject of the beholder, and I think there are clear trade-offs when you try to have some of those interactive related assumptions built in there. You're required to make more assumptions in order to determine what those long range impacts are. And so I think for that reason is why I'm more comfortable, especially when looking at over long periods of time. The simpler the model is often one that is less subject to fluctuation over time, and less fluctuation to the underlying assumptions. And so I think that's where the current preference to kind of have that the reliance on the factors model that has had some additional work on it since those early work. It is clearly where the Office of the Actuary's preference is, but like I said, certainly welcome more research in this area. It only makes all of the work better.
All right, thank you. So I'll now give everyone an opportunity just to say, just very briefly, a couple of remarks, if you want to.
I'll go first, I guess. I think on this last point, you'll end up with fan models, and so it'll be as unclear as the estimates may be to many people from the trustees report as it is now. When you have a fan model, where you have to actually account for the fact that the new assumptions that you're making have a lot of variability to them. That's going to be another thing that will be very difficult to explain to the public. So I think to support Paul Spitalnic's position on this, I believe I'm supporting it, Paul. I think it's very important to try to get some sort of a message that is fundamentally correct, that the public and policymakers, most importantly, can understand. This has been a problem at CBO with dynamic scoring, and it has never gone well.
Yeah, I just want to make a point about I'm going to be looking to see how the Congress reacts to this year's trustees reports, which, as Paul Spitalnic mentioned, it gets 3 years earlier in the projected depletion. And I've seen so many variations. I've seen eras, especially in the 1980s and 1990s, where projected depletion of the funds truly motivated policy action. But I've also seen eras where projected depletion of the funds motivated smoke and mirrors to fix it without making any substantive fiscal changes. We've had a string of the latter where, impending depletion just triggers creativity, and how can we do nothing substantive and avoid this problem? And as deficits and debt has grown larger, we'll see whether we're about to see a turning point where the Congress becomes much more serious about spending and revenue and Medicare.
Probably not a prediction for this year. Paul.
Yeah, they're busy with other stuff this year.
All right, Paul S., do you have anything else?
I think I've said a lot. So I just appreciate the opportunity to come and talk about this year's report, and it's always a pleasure to work with AEI, even if the moderators tend to be the same year in year out. But it's nice to see we have some new blood and. In all seriousness, Joe, congratulations on your retirement, and it's good to see you back here for this.
Well, retirement is not necessarily what I'm doing, but okay, thanks.
Well, thanks everyone for participating. I think it was a great event, and I personally learned a lot, and I hope our audiences as well. And we are now concluding.